Hello and welcome to the Mathematics for Public Health Next Generation seminar with Kevin Brown. I'm going to hand you over to Jumi David, who is our Dr. Jumi David, who is our lead on for the Next Generation, or one of our leads, and she is going to introduce our speaker today.
Thank you so much, Dr. Saïd. Thank you for the introduction. And everyone, thank you for coming today. Today, it's a pleasure to welcome everyone, and especially our guest speaker, Dr. Kevin Brown, to this seminar today. Dr. Brown is an infectious disease epidemiologist and a scientist at Public Health Ontario. He is an assistant professor at the University of Toronto, and he got a master's in biostatistics and PhD in epidemiology at the University of Toronto. So his research is focused on spatial and temporal modeling of infectious diseases with a focus on C. difficile infection, antimicrobial resistance, and more recently, SARS-CoV-2 infection. So today, Dr. Brown will present 3 simple models and what it can tell us about the COVID pandemic in long-term care. And in addition, it will share some insights gained from some of the public health response projects, and also mention how to make the most of our skills in the context of evolving pandemic. So Dr. Brown, you're welcome to present.
Wow, it sounds like I really promised a lot here. So yeah, I'll get started. I'll just share my screen, I guess,
Okay.
which... Yeah, so over the course of the pandemic, you know, I've just kind of, I've done a fair bit of, you know, frantic modeling, and I'll just talk a little bit about some of those projects. The projects that I was working on are kind of interspersed over the course of the pandemic. One of them was from a little bit after that first wave. The first wave in Ontario is kind of deceivingly small. And then the second project that I'm going to talk about was from somewhere between the first and the second wave. And then you know, the last project is kind of like a work in progress. I guess I show this slide as well because actually one of the projects is going to involve kind of the smoothing methods that are used for smoothing out this epidemic curve, which is something that we show on Public Health Ontario's website. But this is a generalized additive model, which is just a statistical model for smoothing splines that involves a little bit of regularization, so it is usually not overfitted. Maybe I should just also say that if anybody wants to interrupt at any time point, just I think you'll actually have to pipe up on the audio. I'm not sure if I'm able to actually see a raised hand. Is that correct, Sarah?
Yeah, I think that's right, but we'll keep an eye out for you as well. But yeah, please shout out a question if you want to ask, because we're not a big group. So
yeah, so like the purpose of this is really to kind of be low key. So feel free to kind of pipe up at any time.
Sure.
Next slide. So I'm going to be talking about a project looking at crowding in long-term care, a project looking at the vaccine rollout in long-term care, and then a project looking at outbreak risk indices. And I'm going to talk a little bit about how, you know, these projects came about. They were all kind of part of a kind of an evolving process of, you know, trying to understand what was going on during the pandemic and trying to identify, you know, potential interventions that could benefit long-term care. So the first question was about looking at crowding in long-term care. And the backstory to this, I mean, I guess there's two dimensions to the backstory. One is that I've been interested in kind of dimensions around design of healthcare facilities for a long period of time. It's kind of related to an interest I had going back to my undergrad when I was interested in kind of the physical environment and how neighborhoods set people up for risks related to kind of risks related to a lot of different factors, including kind of neighborhood gambling. So I've always kind of been interested in environmental risk factors. Another piece to it is that I had been working with Dr. Nathan Stahl, who's the senior author on this paper. And what we had done together before this study was that we had looked at for-profit status in long-term care homes. So long-term care homes in Ontario can be operated by for-profit entities or by nonprofit or municipal entities. And in that study, we had noticed some patterns related to what are called kind of the design standards. So the age of the facility and when a long-term care home was built. And so, yeah, and so the idea here was to kind of have a closer look at that. The issue with that that factor was that it was kind of strongly correlated with actually the number of beds per room. So we actually kind of combined and created what was kind of a mechanism for easily communicating infectious disease transmission risk as a function of the built environment, which was this crowding index. And the crowding index is just the average number of residents per room. And so a big piece to this was actually kind of figuring out that we could use some data sources that we had on nursing homes to actually develop this kind of a crowding measure that would be measured consistently across Ontario's 600 long-term care homes. And then the second piece to this was whether there actually was much variability in crowding across long-term care homes, because if all long-term care homes were designed in the same way, we wouldn't have much to study. And then the third piece was, obviously whether crowding was associated with COVID-19. So I'm just going to kind of jump right into the actual some of these findings. And if you guys have questions about the specific kind of statistical models or those types of details, feel free to ask me. I'm not really going into the nitty-gritty of the actual models. I'm kind of trying to tell you the story of these modeling based projects, because I'm kind of a lot older than you guys, and I presume that you probably have a lot stronger and actual technical modeling skill set than I do. So I could talk about the modeling approaches if you want me to, but I'm not going to kind of bore you too much with that. So this is what our crowding index looks like, and so this crowding index represents the average number of patients per room. So we arbitrarily split it at a crowding index of less than 2 and a crowding index of between 2 and 4, and that's what the two different colors are. So a crowding index of 1 would mean that every single resident in a long-term care home was in a private room, and a crowding index of 2 would mean that every every resident in the long-term care home had one roommate, and so on and so forth. But you could have a home that has a mix of one-bedded rooms and two-bedded rooms, and maybe it will have a crowding index of 1.5 and whatnot. So it's just a weighted average. And you can see, and the other piece is that we considered there's a lot of rooms with shared bathrooms, and so we considered rooms with shared bathrooms to have a crowding index of 1.5. So that's the piece about the actual the variability. So we saw quite a bit of variability in the crowding index across the province. So you really saw there's a spike in kind of newer designed homes that all tend to seem to be built with a mix of one and two bedded rooms. And there is a lot of older homes that seem to be built with a mix of, 1, 2, and 4 bedded rooms. And that's what.
Sorry, just quick question. I don't mean to
Sure.
interrupt. Just curious why you grouped it as less than 2, because it seems like there's like a natural break of like greater than 2. I'm sure it wouldn't make that much difference because there's not that much at 2, but just wondering about that break.
To be honest, it's strictly because of the the number 2 and
Okay.
to communicate it to people. There are just a couple homes here, and you're right, but these seem to be places that we could have done less than or equal to, but I don't think they were actually 2.0. I think they're probably 2.05 or something like that, because 2.0 here is we've actually rounded it down, I guess, so it's kind of the bottom of the range.
Okay, thanks.
Yeah. And the main analyses are based on the actual crowding index. So this was mostly for communicating and presenting the data as opposed to the basis of the actual analysis. Yeah, so we used, I believe, Poisson regression, or I believe we used Poisson regression to just straight up measure the association between the crowding index and the incidence of COVID-19 in the first wave. And then we also looked at the incidence of COVID-19 associated deaths in the first wave per long-term care home. And we saw quite a strong kind of positive association between the two, and this was really a pretty simple model. We also broke things down into risks of an introduction. So we also had risks of having one case versus risks of having a larger outbreak, and so the association was stronger for kind of spread. So we had the risks of having a larger outbreak given that introduction had occurred. So we did these two separate models to kind of try and tease out a little bit of try to strengthen the point that the crowding index would be expected to have a stronger association, not on introductions, but on spread given introduction. And so that was a separate model on top of this, but this incidence measure is just the overall proportion of residents that were infected during the first wave, and that's what you're seeing here. So I'm not going to talk much more about this project right now. Just let me know if you have, I'm going to kind of talk about all the projects a little bit at the end, kind of in a kind of shared discussion. So in this second project, so that project was kind of really one of the first projects that happened right after the first wave. This second project was later on. early in 2021, so at the beginning of this year, where we looked at, we wanted to provide a look at the effectiveness of the vaccine rollout in long-term care homes. And I think there was a lot of anxiety around whether, the vaccine rollout would actually suppress case growth sufficiently in the long-term care settings. And another piece to this was that, we had done so much work talking about some of the problems with the COVID response in long-term care. And this was, maybe a bit of a good news story. So we wanted to look at how we wanted to kind of talk and show the Ontario public a little bit how long-term care homes had been prioritized for vaccination. At this time point, this was as the rollout was occurring, that this was published. So we wanted to know we wanted to kind of show how many long-term care home residents and workers had actually received the vaccine. And we wanted to provide an estimate of the impact of the vaccine rollout. And, there'd already been a lot of studies of looking at the efficacy of the vaccine at an individual level, but this was very different. This was actually kind of there was still a story to be told from a more public health perspective about the efficacy of the vaccination program as opposed to the efficacies of the clinical efficacy of the vaccine itself. And so that's what this project was about. So this slide relates more to especially to the piece about measuring the efficacy of the program. We really focused, we used available data sources. Once again, we used data that we had and that was convenient and that was maybe not the most clinically detailed data, but it was available at the time, right? We were working with what we had. So we used the case and contact management system. The other piece of information that's not listed here is that we poured over public health unit websites what we looked for was the dates when the public health unit said they started administering vaccine doses in long-term care, and the dates at which they said they completed administering doses to long-term care facilities, and we had those numbers for the first dose, and then we didn't actually distinguish second doses in this analysis, so we focused really on first doses, and in order to kind of infer a control population, what we did was we used a design called a difference in differences analysis. And so a difference in differences analysis is a longitudinal study design that usually has two groups and a pre-intervention and a post-intervention kind of time trend. Oftentimes these are extremely simple models. They'll have they'll measure a linear time trend in a pre-intervention period and a linear time in a post-intervention period. And your intervention effect is the difference in the difference in level and trend that occurs in the post-intervention period for the intervention group. The reason I mentioned kind of the smoothing spline model in that first, those generalized additive models in that first slide is because I use these a lot in this for this analysis. So what we did is we did this difference in differences analysis where we had a date of kind of implementation of an intervention and a time since implementation of an intervention. And for each of the public health units, we had a different date. So we did this analysis at the level of each of the 34 public health units. And then we looked at long-term care resident cases, deaths, and long-term care healthcare worker cases and deaths. And because data was really sparse for healthcare worker hospitalizations, we kind of we actually just multiplied the incidence by the anticipated hospitalization rate to provide an estimate of how many the prevented infections, to get an estimate of the prevented hospitalizations. And so in terms of data, what we did is we just kind of rummaged the public health unit websites and talked with our contacts in the public health units and asked them when they had kind of started and completed their vaccine rollouts. So what we found was that there were 8 public health units, and these were prioritized by the Ministry of Long-Term Care. These were public health units that had the vast majority of resident and healthcare worker infections. And in particular, you had Toronto, Peel, and York, but you also had Windsor. So these were kind of the larger PHUs, the more urban PHUs, as well as the high incidence public health units that were prioritized in this first batch. Then we had this second batch of public health units, and they finished their rollout basically a week and a half or 2 weeks later. And then the last batch of public health units finished their rollout of vaccine, of the first dose of vaccine, another 2 weeks after that. And so, when we were writing this, it was kind of at the end of February. And so, or I guess it was the beginning of March at this point. And what we showed was that 92% of residents had received, or we estimated that around 92% had received 1 dose, and that not an extremely large proportion of healthcare workers had received 1 dose. And so this is kind of a slide that shows what that modeling approach kind of created. So we had, and what I'm showing here is the cumulative model from across the 34 healthcare units, because a model like this was actually fit for each of the public health units, because they each had a different completion date for the long-term care rollout. And our control groups are in red here, and the intervention group, which are in this case it's the long-term care workers, and in this case it's healthcare workers. So the control group for the healthcare workers in the difference in differences design is our working age adults, and the control group in the resident curve is are the older people in the community. So we had these community-based control groups that didn't experience the intervention, in that they were groups that hadn't actually, the vaccine rollout hadn't actually been applied to them yet. So we thought they were kind of a pretty reasonable control group. And so you see the basis of this model. The y-axis is just the number of COVID-19 infections per day, but we've actually just, for the purposes of the visualization, forced it to be 100% on November 1st for each of the 2 groups. So you see the nature of the difference in differences design is that the trends are forced to be parallel in the pre-intervention period. And you see that's actually generally the case. The wiggly blue line follows the wiggly pink line in the pre-intervention period. And then we actually allow we use the spline to define kind of the post-intervention, the effect as a function of the number of days since the start of the vaccine rollout in the it was actually based on the midpoint of the vaccine rollout in the first dose rollout in the public health unit. And so you see the spline starts to separate and is allowed to separate smoothly from that point. And it's really, you know, the effect of the intervention is kind of the spread between these two lines. And this is what's measured in a generalized additive model that kind of fits these splines. So really you just have kind of one spline for the control group, and then you have a second spline for the time since the intervention in the active treatment group, which is the long-term care home residents and the healthcare workers.
Kevin?
Yeah.
I have a quick question.
Yeah, for sure.
So I was just wondering, like, on what basis were the control group chosen? Because usually the vaccine rollout is for some group, like maybe underlying illness or due to age. So could it be because of some other factors? That's why we have the COVID lower in the higher in the control group or LTC group. So do we say the vaccine worked, or maybe other factors? I'm just wondering.
Yeah, so you raise a great point. But the design, these two groups could have had very different absolute levels in the pre-intervention period, right? So the lines that you're seeing have already been scaled. They're not actually the same. The incidence, they're not, first of all, they're not incidence rates, they're simply absolute counts. And second of all, the incidence would have to change differentially for the two groups. So it could very well be that some of these people in the community, like you say, that are 70 and older have underlying illnesses, but that wouldn't actually make you expect that the trends in these two groups would diverge for any reason, because in general, what we saw over the course of the entire pandemic was that community cases and long-term care home cases followed very similar trends. Long-term care homes were highly impacted by the communities, and so the shape of their curves was different, was the same, but the levels were potentially different.
Thank you.
It's a good question. So it's just that the shape, the model assumes the shape should be similar in the pre-intervention period, and that the intervention impacts the shape of the incidence curve, basically. And so then if you can actually take the curve, you can actually kind of plot out the curve of the gap between the two, between your intervention and your control group in both of these, and plot that out. And that's actually kind of your measure of the relative efficacy of the vaccine rollout as a function of days since the beginning of the rollout. And so that's what this is here. So you see, as a function of the number of weeks since the public health unit vaccination, you can see it's obviously forced to be 1 at the beginning, and then the relative risk of infection in the long-term care worker group, rapidly decreases. So their incidence, their daily incidence of COVID rapidly decreases. So sorry about the colors. So the colors the colors in this graph represent residents and healthcare workers, whereas the colors in the other graph represented the control and intervention groups. But so they don't quite correspond. But that's what you see here.
Sorry, would I be able to ask a quick question?
Yeah, for sure.
Could you go back one?
Yeah, sure.
So I'm wondering, like, I understand data is super messy and I can't imagine how difficult it is to do this. But I guess for a couple points, like I see when you're looking at the long-term care, you have like lower bottom points. The lows get lower, but sometimes like even in the residents, when you go up all the way past January, it almost feels like it's like largely overlapping. And I wonder, like, for separating them, like why they diverge the way that they do. And also even with like the healthcare workers, especially because the variance of the long-term care, it's so much larger than your control group from what's there. Again, like for me, there's like a clear separation in February. You can see all of a sudden in both cases, they like completely split. But before then, given like how much noise you have in your data, was it really challenging to try and like detect a signal, and how much do you trust and say, you know what, like 100%, you know, we're really like picking up this signal?
I mean, I think that there's a piece that's a little bit like interpolation, because the model knows that eventually it gets to this point, right? At the end. And so there's
I see. Okay.
Separation at the end, and they're forced to be together at the beginning. And the way a spline works is that it has to get from that point to another point through a smooth process. And so there are some, you're right, I was kind of always freaked out by these higher points, and so there is some higher points that have with a lot of overlap. But the model, actually, we kind of set it up somewhat in a somewhat a priori way that we just said, you know, we'll let the model assess the, you know, time lag of the effect itself. And so you actually see in this model right here in the healthcare workers, the two lines are closer together for a longer period, right? And then they come down, and then they separate much later in the healthcare workers, whereas in the residents, they really separate
sorry,
earlier.
could I just ask a question? Yeah, like especially with the healthcare workers, like is there a way to make that difference steeper faster, or is this just like a property of the model? Because like in that, looking, like I said, by the time that you get to February, all of a sudden you see that really clear difference. So is there a way that it could have been, you know, you have that similar result all the way through, and then all of a sudden it's like a huge difference? Because it seems like it's separating it earlier. And I was wondering, to like what degree do you think that separation was so gradual, I guess would be my question, versus like much more stark, which it looks like in the raw data.
Are you talking about the residents or the healthcare?
Healthcare workers, because you can see it for me, like it's much more obvious that like all of a sudden, like once you get past, especially mid-January, but especially February, all of a sudden the data like clearly split between the control and the long-term care. Whereas like prior to that, like if you get to early January, especially end or mid-January for healthcare workers, like it feels like it's almost largely overlapping the control with the long-term care. And I know you said it's the property of the model that it has to get to that ending state, but I was wondering if it could stay together closer longer and have a more rapid divergence later on in time.
Yeah, this is kind of a nice thing about the like a generalized additive model. It's a model that allows you not to worry too much about, you know, most of these spline-based models. An issue with splines is that you have to make these somewhat arbitrary decisions about how many knots to add to the model. And so the generalized additive model approach has some regularization. So it actually enables you to add too many knots, actually, and you let the model decide how much smoothing is actually required, right? So it actually allows it to be as wiggly as it wants. And this is actually how the model decided based on the data to separate out these two curves and where the mean of those lines was. So I think actually what it's showing is that the mean actually was in those the separation probably did occur where it occurred in these models. But I mean, I think there's probably a certain amount of uncertainty, especially in kind of that mid-January period where they were obviously in the process of separating, but weren't quite there yet. But I see you think the separation may have happened far more suddenly in February. I mean, I think based on like an a priori hypothesis here, you would about when the actual vaccine rollout occurred and when these people were being vaccinated, the separation is more likely to have occurred a bit earlier. But we didn't have that super granular data about how many doses were administered each day at this point that we were doing this. So ideally we would have had that information, and then we would have actually been able to know for sure whether that distinction really did happen at the end of January, because more workers were actually vaccinated in mid-January than they were actually during the vaccine rollout in December.
Yeah, that makes sense. Thank you.
No problem. Okay, so I should probably roll along. So you see, these are the effects. So the effects are actually just on the basis of, on the basis of those separation curves. Like, so these are the actual splines that were modeled. And to your point, you can see that for the healthcare workers, this spline actually stayed very close to 1 for a few weeks after the initial vaccine rollout, before separating smoothly. Whereas for the resident curves, it kind of dropped more rapidly and kind of in a more linear looking fashion. And so you can kind of then measure the cumulative number of cases and deaths averted as a function of that model. So it's just kind of accumulating that throughout those curves that you saw throughout time. And then you can estimate the number of cases and deaths prevented from the vaccine rollout. The other piece that's really important that this work kind of helped, I think, expressed to people was how effective the actual public health interventions were in this time period. So, those curves were actually already dropping by the time the curves separated. Actually, both curves were dropping at the time that the vaccine rollout occurred. And so this approach actually allowed us to separate out the kind of the public health measure piece, which was, the trends that you saw in the controls and the trends that you saw in the specific long-term care population. And so the third piece I wanted to talk about, and I really wanted to leave, a substantial amount of time for questions and discussion at the end. So I'm just gonna kind of try and rush through these last slides so that we have at least 15 minutes. So, so we know, so this is a project that I'm kind of, that's in progress that, that I just wasn't able to, to get out the door in the middle of the long-term care outbreaks, but I think would be something that's very helpful to know, because we had a lot of extremely severe COVID-19 outbreaks in long-term care homes, devastating outbreaks really that occurred in long-term care homes that are literally right around the corner from where I live, that are in, Bobcaygeon, that are, and what I wanted to know, or what we felt was important to know for this project was we know very little about how these outbreaks actually evolved over time. And we didn't know how bad an outbreak was going to be at the beginning of the outbreak. So the objective of this project was to kind of understand some of these more granular dynamics of a COVID-19 outbreak in a long-term care home. And in particular, kind of the take home that I wanted to have was that from this wasn't like a mathematical modeling project to actually perfectly understand the entire dynamics. It was to actually understand the dynamics of incidents based on the first time point that you know that the outbreak is occurring. And so I'll kind of jump into that a little bit now. So the basic idea underlying this probably resembles most this concept in ecology called propagule pressure. And the general idea is that in general biologic invasion. So they're talking about species kind of colonizing different islands or regions. Whether these are in general, they're talking about invasive species. And they can appear to be very idiosyncratic, but actually in general, they're really oftentimes related to just the size and the frequency of kind of releases of these invasive species. And so to apply this idea, and so the idea is generally like the propagule pressure is associated with the probability of establishment. And so I wanted to apply this idea to a long-term care outbreak. So in this case, the probability of an outbreak being large is a function of the seed that you observe at the time that you identify the outbreak. And so what we did was we had outbreaks on, we have data on 600 or more long-term care home outbreaks. And we had a definition for an outbreak based on, there being cases within 14 days of each other over the course of a time period. And we defined an outbreak identification date, which is the date that the first test result is reported. And then we defined, what I call infection pressure or propagule pressure, the propagule pressure in equivalent, which is infection pressure. And so we measured infection pressure just as the number of person days of infectiousness that you observe at the time that you're identifying an outbreak. And that infection pressure obviously stops when residents and staff are hospitalized or they die. And we've also made some assumptions, or we're kind of exploring the role of a specimen collection, because the fact that you collect a specimen means that you're aware that someone is at risk of having COVID, and that person should be put into the contact precautions should be applied to a resident that has a specimen that's been collected. And then we did separate measures for staff and for resident, because a staff actually won't go to a long-term care home after they've had a specimen collected, because it means there'll be a suspected case, and they'll be told to isolate at home. And then resident infection pressure, a resident after they've had a specimen collected is actually stays in the home. And we're also examining this negative control exposure. And so our outcome here is the number of at-risk residents, I should actually say, that developed symptoms or infection in the 30 days after the outbreak identification date. So we split outbreaks in the middle, not in the middle, presumably at the very beginning of the outbreak. And then we also looked at deaths among infected residents. So we have this kind of index period, and we have a follow-up period. We look at several different follow-up periods, but the entire outbreak kind of starts from one side of this graph and goes all the way to the other. But the exposure measures that we're interested in here relate to this index period, and then we're looking at outcomes in a follow-up period. And one thing that maybe the modelers will bulk out a little bit is just that many of the people that show up in this period were actually potentially infected in the index period. But I believe the way an infection control practitioner would use this is that they would actually, you'd still want to know how many cases you can expect will show up based on information that you know at the time of the outbreak is identified. So here's what kind of the measure could look like. So you could have like a staff onset case, and that staff was in the facility. They were symptomatic. They were symptomatic. They kind of apply infection pressure, and that's what these small square dots are, for 2 days before their symptom onset date. And so the little square man shows up on the symptom onset date, and then they have had a specimen collected 3 days afterwards. So I haven't actually shown it here, but for each of these dot diagrams, I presume that a specimen's collected on the 3rd day afterwards. So that's why these dots stop showing up for the staff case, and for the resident cases, I've just kind of split these two into 2 different types of infection pressure. Hope that's clear. And so that's the general idea behind the project, where we've started to look at it, and as you might expect, there's a strong association. So we're hoping that this kind of a measure, infection pressure based measure, could help risk stratify outbreaks so that long-term care homes can do better planning, I guess, for management of an outbreak, and so that the healthcare system can kind of anticipate what might be needed in terms of PPE, in terms of staffing, and other resources. Anyhow, so I wanted to kind of talk a little bit, or wrap up and think about some of the learnings from over the course of the pandemic, and basically so we have this information about how these nursing home populations were extremely vulnerable, due to the high case fatality, because they were they represent older and sicker individuals, but also because of the congregate care aspect of their living situations. So that mix created, a very potent outbreaks in Ontario. And then kind of the other findings here are that, crowding is this very measurable and modifiable risk factor for COVID-19. Vaccine impacts, they can be understood at an individual and at an institutional level. You can kind of expect that if you're looking at vaccine effects at an institutional level, you may actually see stronger effects, or theory would actually predict that you see stronger vaccine effects when you're kind of aggregating the effect, both the transmission prevention, as well as kind of the reducing the transmission that occurs, as well as the individual protection. So the direct and indirect effects amplify each other. And then hopefully infection pressure can kind of help risk stratify future outbreaks, at the time that they're identified, so this measure could potentially be used in real time. And over the course of the pandemic, I've thought a lot about how to kind of risk stratify, or how to prepare, for future pandemic waves, and how do we focus efforts. And there's a lot of strategies for trying to evaluate the quality of a potential intervention, how strong you think the intervention could be based on theory. So NIOSH, which is a US institution, has a kind of a hierarchy of control measures that range from kind of the highest on the hierarchy, which is kind of eliminating the source of the threat, to very low level strategies like focusing on personal protective equipment. The Haddon matrix, which is used in injury prevention a lot, talks about looking at interventions that can be done in the prior to the event, during the event, or after the event. And I would add an additional dimension around measurability. So how easy it is to measure whether this intervention or this exposure that you're interested in is present or absent, because a lot of interventions that were highlighted in the SARS report in 2003 were things relating to kind of infection control preparedness for different types of healthcare facilities, and for sometimes these infection control preparedness is actually something that's quite difficult to measure, whereas things like crowding of a building could be highly measurable and are kind of engineering controls that are easy to have in place beforehand. And I think another way to prepare for future pandemics is just to make sure that we're really doing a great job of preventing transmission of seasonal respiratory infections, and any learnings that we get from seasonal respiratory infections, we should be able to apply to pandemic infections. And so, I have a fair bit of future work that relates to these projects. And then a few additional discussion points, just kind of very broad level things, is that, when it comes to, data, one person's trash is really another person's treasure. And this is something that my thesis supervisor would say around kind of David Fissman, around data raccooning and data thieving. You really, there is data out there for you to use and to leverage, and you shouldn't be afraid of with your skill set. You should I guess try to leverage the data that you have, and just because it's not the ideal data source doesn't mean it's imperfect. Another piece is that there's a lot of really exciting public health questions that remain understudied. And when it comes to pandemic response, timing is pretty important. And so that's all I'll share for now. Hopefully I've left a little bit of time for a discussion.
Thank you so much for the great presentation. Do we have questions from anyone? Questions? Maybe we asked all of the. Oh, Corinne, do you have a question?
Yes, but I see that Elizabeth had one, and I've asked a lot. So go ahead, Elizabeth.
Oh, sure. I was just going to ask Kevin, this seems like a great set of ideas to apply to schools, like crowding and the risk of an outbreak, given that there's been an introduction, the age of the building, type of ventilation, etc. Just wondering if you're thinking about doing something like that, or anyone else.
Well, I wonder, it's a good question. Like, I wonder if there's variability in schools, because every classroom will be about the same size in a school. So I guess it would be more about the number of classrooms in a school. So that would be like an interesting piece, actually, just kind of the overall number of students in a school.
Yeah.
Kind of a driving factor for school-related outbreaks. No, I haven't thought of that, actually, or I haven't toyed with that idea, but it would be great to, if someone's involved in school outbreak modeling, to look into that. It seems like it wouldn't be too difficult to get that kind of information, the attendance of a school, right?
Yeah, so the town of Huntsville, which is where I live, it's been an interesting case for the month of November, because there's been introductions in 5 of the 7 schools, and 2 of them have gone on to quite significant outbreaks, with one of them closing. But before that, we were like at 0 per 100, like 0 cases almost. So, and we've gone up to 160 per 100,000, even though like our population is very small, but I just thought that would be an interesting thing to study. Anyway, that's my comment. It was a great talk. Thank you.
I think that there is kind of public information out there on school outbreaks. So, you could probably look into that.
If anyone's interested, the Simcoe Muskoka District Health Unit has school outbreak data, not daily cases, but you can look at the ages on the daily cases, and then it gives the total number of school cases per outbreak in their data set, which you can't get from the publicly available Ontario data set. So that's kind of interesting. They have good data.
Yeah, that's a good point. No, it's not something that I had thought about, but it would be definitely, it would be interesting to look at. Might not be totally modifiable, but it would at least indicate whether, you know, the practices around cohorting are being applied properly or not.
Yeah, that's another good question.
Like, because in theory, you know, the size of the school shouldn't matter if your classes are properly cohorted.
Well, yeah, but like the bus driver shortage sort of throws a wrench into that, because, you know, the buses here are going to 3 and 4 different schools. So there's a lot of funny things going on that sort of make the cohort irrelevant almost. Anyway.
Yeah, no, like those are like really important points, and that's why you would do this analysis. You'd be able to kind of show, you know, to what extent there's still residual impacts of, you know, school size on these outbreaks.
So thanks again. Thank you.
Great. Corey, your question?
Sure, I can just ask it really quickly. So I really liked the Hadon matrix, I think, that you put up, and talking about measurability. So just for what is feasible, what do you think we could do next time around that would be something measurable that we could actually calculate the effect of whatever intervention, and at what point in the process? So I like the crowding buildings, but is there anything else that you would recommend? Let's say that you had sway.
Yeah, I mean, the other massive issue in long-term care is staffing. And so I think a lot of, we don't know how these long-term care homes are staffed, or we know that they're just scraping by, many of them, like with the lowest level of staffing possible. And staffing causes issues because when you have an outbreak, you know, you have to don and doff PPE, and very quickly, you know, the staff will get overwhelmed and then won't be able to apply those PPE practices properly, or won't be able to care for the number of patients that they have to care for, or not patients, residents. So the staffing piece, the issue is that we have no data on it at the moment, or we're just in the process of starting to collect data. And in the US, they've, as part of the Affordable Care Act, they actually implemented a really kind of progressive approach to measuring staffing, where they just actually have shift-based data, payroll data that the facilities have to submit. And so that would be like a really important kind of piece to tackle, because the staffing piece is we know that it's important. We just don't have the data to make real recommendations around, other than to collect better data at the moment. So that's one of the pieces that we're trying, that we're trying to kind of investigate a little bit more deeply. It was part of the report that we did for the science brief. We had a piece about data and the staffing issues. Some of the differences between for-profit, not-for-profit, and municipal facilities are largely driven by staffing, and by, in particular, there's a lot of complexity in the staffing issue, because there's temp agencies that play a role, where you have people that work at multiple different facilities. So even if your institution isn't a for-profit institution, they'll still, like if you're like a not-for-profit, you still might be using staff from a temp agency or a staffing agency that's getting people from, that's itself for-profit. So definitely.
Awesome. Thank you.
I'll repeat it again. Maybe I haven't said it enough times. So that's one piece.
So because of time and because of the next discussion, we won't be taking further questions. So on behalf of everyone here today, thank you, Dr. Brown, for taking the time to speak on these very important topics, and especially your explanation on using a very simple model to feed a spline was very inspirational to me, and I'm sure to many people as well. And once again, on behalf of the Mathematics for Public Health Next Generation team, I want to say thank you for coming.
It was a pleasure.
And